Welcome to the deep dive. Today we're tackling a topic that, well, you might not think about every day, but it really does affect a lot of people. Lymphedema.
That's right.
We've got chapters here from Rutherford's vascular surgery and endovascular therapy, basically the go-to guide for experts.
Hmm.
And we're focusing on, how they evaluate and make decisions about this condition.
Exactly.
Our mission, really, is to give you the key insights, what lymphedema is, why it happens,
It's identified.
and maybe even a peek at future treatments, all without, hopefully, getting bogged down in medical speak.
Yeah, we want to pull out the essentials from these pretty dense chapters and make it, well, digestible for you.
Okay, sounds good. So let's just jump right in. In simple terms, what is lymphedema?
Okay, so imagine your body has this secondary drainage system, little pipes, basically.
Right.
They clear out extra fluid and waste products.
Right.
Lymphedema happens when that system, the lymphatic system, isn't working properly. So you get this buildup of fluid in your tissue.
Your fluid, like water.
Well, that's the key thing. It's not just water. It's fluid that's really rich in proteins. Think of it as like a thicker fluid.
Ah, okay.
And the lymphatic system really struggles to move that thicker stuff along. And this backup, it's progressive. It tends to get worse over time.
And why does the system fail?
It's usually down to a problem with the lymphatic vessels themselves. Either someone's born with defects in the system, this primary lymphedema.
Okay.
Sometimes we don't even know the exact cause of that primary type. We call that cryptogenic.
Right.
Or something happens later in life that damages the system. That's secondary lymphedema.
And that's more common.
Generally, yes. And while it can affect internal organs, usually the most obvious sign you see is swelling in an arm or a leg.
So, like, the body's plumbing gets clogged up. What actually happens when that outflow is blocked?
That's a pretty good analogy, actually. When the lymphatics can't drain properly, it causes a cascade of events. Normally, they take this protein-heavy fluid back into the bloodstream. If that outflow is slow or blocked, these proteins and other cellular bits and pieces start to pile up in the spaces between the cells.
And the proteins are the problem.
They're a big part of it. Because proteins naturally attract water, its basic physics really increases the tissue colloid osmotic pressure.
Like a sponge soaking up water.
Exactly like that. So the protein buildup in the tissues pulls in more and more water, and that leads to the edema, the swelling that we see.
Okay, so a backup, then water retention. Are there different ways the system can fail, like different types of failure?
Yeah, we can broadly think of it in two main ways. First, there's what's called high input failure.
High input.
Yeah, think of a sink drain that's working okay, but the faucet is just blasting water. Too much fluid is being produced at the capillary level for even a healthy lymphatic system to handle.
Like in other conditions.
Exactly, like sometimes happens with venous edema, the lymphatics just get overwhelmed.
Okay, that makes sense. What's the other type?
The other is low output failure. And this is where the lymphatic system itself is the problem.
How so?
Well, it could be that someone just doesn't have enough lymphatic vessels.
Yeah.
That's called hypoplasia,
Fewer pipes?
right? Or in some severe cases, they might be missing altogether. That's aplasia.
Ew. Wow.
Or there could be issues with the tiny valves inside the vessels. They're meant to keep fluid moving one way, but if they're leaky, you get backflow.
Uh-huh.
And sometimes the vessels just don't contract properly to push the fluid along. Problems with contractility.
And it sounds like this isn't just about temporary swelling. The source mentioned longer-term tissue changes.
Oh, absolutely.
Ew.
If this lymph stasis, this traffic jam, goes on for a long time, the tissues themselves start to change structurally.
How?
Certain molecules, like hyaluronin and other glycoproteins, build up in those spaces between cells.
Okay.
And this buildup seems to stimulate the growth of various cells, fibroblasts, which make connective tissue,
Uh-huh.
keratinocytes, which are skin cells, and also adipocytes, fat cells.
So the tissue gets thicker.
Exactly. Over time, you get more collagen deposited. That's a tough protein, leading to what we call subcutaneous fibrosis, hardening under the skin.
And that's permanent.
It often leads to progressive hardening.
Yeah.
We don't fully understand all the mechanisms, but this fibrosis is a real hallmark of chronic lymphedema.
It sounds like there are quite a few variations here. How do doctors start to sort through all this? How do they classify lymphedema?
Well, the most basic split is the one we mentioned, primary versus secondary.
Born with it versus acquired it.
Right. Did it arise on its own, maybe due to those inherent defects, or did something else cause it later on? That's the first big question.
Okay.
But within primary lymphedema especially, there's a lot of variety, so doctors break it down further, which really helps understand what's going on.
Right, let's dig into those primary types then. The outline mentioned genetics and age of onset.
Yeah, exactly. So for primary, you can look at genetics.
Yeah.
Does it run in the family? That's familial. Or does it just seem to appear out of nowhere?
Uh-huh.
That's sporadic.
Huh.
Then you look at when the swelling first shows up. If it's there right at birth, that's congenital lymphedema.
Okay.
Lymphedema precox is actually the most common type. It usually appears around puberty, maybe up into the 30s.
Precox meaning early.
Kind of, yeah. Earlier than tarda, anyway.
Mm-hmm.
Lymphedema tarda is when it develops later, after age 35.
Got it. The source seemed to have a bit more detail on the congenital type.
It did. Congenital can be sporadic, but when it's familial, it often follows an autosomal dominant inheritance pattern.
Meaning?
Meaning if one parent has the gene, there's a good chance the child will inherit the condition. It's also seen more often with certain chromosomal issues like Turner syndrome, Klinefelter, Down syndrome.
And where does the swelling appear?
It can vary a lot. Sometimes just one limb, sometimes multiple limbs, genitals, even the face.
Huh.
In males with congenital lymphedema, it seems more common to affect both legs and the whole leg.
Okay. And lymphedema precox, the most common one. Any typical patterns there?
Yes, definitely. Precox hits females much more often than males, a strong female predominance.
Interesting. Why?
There's some thought that maybe estrogen plays a role, but it's not fully confirmed.
Yeah.
Usually the swelling is just on one side, unilateral,
Uh-huh.
and often limited to just the foot and calf area.
Yeah.
Historically, if this type ran in families and started at puberty, they called it Meige disease.
And tarda is just later onset, less common.
Right, after 35 and, yeah, relatively less common than precox.
Okay, so beyond when it starts, the source also mentioned classifying by morphology the actual structure of the lymph vessels. What kind of problems can they have?
Right, this looks at the pipes themselves.
Ah.
Aplasia means the collecting vessels are just missing in an area.
Completely gone.
Yeah. Hypoplasia means there are fewer vessels than normal, or they're underdeveloped.
Okay.
Then you can have numerical hyperplasia, more vessels than usual, but they might not work right.
More isn't always better then.
Apparently not.
Right.
And then there's just hyperplasia, which often implies not just more vessels, but vessels that are dilated, maybe twisted, with leaky valves, sometimes called megalymphatics or lymphedema.
Enlarged lymph vessels.
Exactly. This pattern seems more common in males, often affects the whole lower leg on one side. You might see other things too, like little skin angiomas, or that chylous reflux milky fluid backing up.
And that sounds more serious?
Generally, yeah. Having these megalymphatics often points to a more involved condition with potentially a worse prognosis.
That's a lot of structural variation.
Yeah.
And then there's location distal versus proximal, lower leg versus upper leg.
Yes, where the main problem lies anatomically matters too. If the issue, say aplasia or hypoplasia, is mainly in the distal lymphatics lower leg, it often presents as milder swelling, maybe bilateral, and more often in women. The outlook is generally better. The swelling might reach its maximum extent early on and not progress much, though the limb girth can still increase.
And if the problem's higher up, proximal.
If the defect is in the proximal lymphatics or the lymph nodes, maybe intranodal fibrosis. But the distal vessels are okay initially. That often leads to more severe unilateral swelling. Slightly more common in women again. This type tends to get worse over time, might need surgery. And interestingly, those distal vessels can eventually get damaged too.
So the problem can spread downwards.
It seems so sometimes. There's also a less common bilateral hyperplasia pattern, slightly more male predominance. And isolated proximal hypoplasia often means the whole limb gets involved and the edema tends to worsen.
Okay. The outline also mentions clinical setting like other associated conditions or features.
Right. This looks at whether the lymphedema is part of a bigger picture. Is it isolated, or does it come with other distinct physical traits or known syndromes?
It's like syndromes we've heard of.
Sometimes. While sporadic cases are most common, congenital forms can definitely cluster in families. Milroy disease is the classic example of an autosomal dominant inherited type.
Right.
There are also rarer recessive inherited forms and many, many genetic syndromes where lymphedema is one component. Think chromosomal issues like Turner, Klinefelter, Noonan syndrome, and even links to vascular anomalies because lymphatics and blood vessels share developmental origins. There are actually diagnostic algorithms now to help figure out these primary lymphatic issues and guide genetic testing if needed.
And finding these genetic links must be giving clues about what's going wrong at a really basic level.
Absolutely. It's hugely important for research. Many inherited forms are being mapped to specific genes, like lymphedema cholestasis syndrome, a GINA syndrome that's linked to chromosome 15q.
Okay.
Milroy disease, we know that's often due to mutations in the VEGFR3 gene. That gene is critical for lymphatic vessel development.
So a mutation messes up development.
Exactly. It affects the signaling needed for lymphatics to form correctly. Other genes like FOXC2 are linked to different primary lymphedema patterns. And SOX8 mutations cause a syndrome with hair loss, lymphedema, and telangiectasias.
So understanding the genetics really opens doors.
It really does. It gives us fundamental insights into how these vessels work or don't work.
Okay, that's a deep dive into primary. But you said secondary is actually more common overall. What usually causes that?
That's right. Acquired or secondary lymphedema is what we see most often. And in developed countries like the U.S., the number one cause is, unfortunately, iatrogenic, meaning it's related to medical treatment.
Treatment for what, usually?
Primarily cancer treatment, surgery involving lymph node dissection, and/or radiation therapy. These can both damage or destroy lymphatic pathways.
And that's a big factor for certain cancers.
Yes, a major one. Breast cancer treatment is the most frequent cause of lymphedema in the arm. Removing nodes in the armpit, radiation to that area, both contribute.
Even with modern techniques.
Even with advances like sentinel node biopsy and more targeted radiation, a significant number of survivors still develop arm lymphedema. It's a real quality of life issue.
And other cancers, too.
Oh, yes.
Yeah.
Treatments for gynecologic cancers, urologic cancers, prostate cancer, they can lead to lymphedema in the legs or pelvis. Melanoma treatment, if it involves extensive node dissection in the groin or armpit, can also cause it in the limb.
The source also flagged filariasis as a huge cause globally, maybe less familiar to us here.
Very true. Filariasis is actually the most common cause of secondary lymphedema worldwide. It's caused by parasitic worms.
Worms?
Yeah, tiny nematode worms like Wucheria bancrofti, Brugia species. They're spread by mosquitoes, especially in tropical and subtropical areas, often linked to poor sanitation.
And how do the worms cause lymphedema?
The adult worms live in the lymphatic system. They cause inflammation, scarring around the vessels, sclerosis in the lymph nodes.
Wow.
Plus, things the worms release, the body's immune reaction to the worms. It all leads to node fibrosis, overgrowth of lymphatic tissue, dilated channels. You often see high eosinophil counts in the blood.
Eosinophils being a type of white blood cell.
Right, often involved in parasitic infections or allergic reactions. And sometimes you can even find the larval worms, microfilariae, in blood or lymph fluid.
And this can get really severe.
Sadly, yes. It can progress quite rapidly in some cases to what's called elephantiasis extreme, disfiguring swelling and skin thickening. Very difficult to manage.
Are there other causes of secondary lymphedema besides cancer treatment and filariasis?
Yes, a whole range of things, less common. Significant trauma to the lymphatics, like from major burns or large wounds.
Okay.
Pregnancy can sometimes trigger it. Infections, bacterial, fungal, even infections after bites. Certain skin conditions like contact dermatitis, even a rheumatoid arthritis has been linked.
Arthritis.
How? The mechanism isn't totally clear. There's a hypothesis about autoimmune destruction of lymphatics in some cases, but it's not proven. Basically, anything that severely damages or obstructs the lymphatic pathways can potentially lead to secondary lymphedema.
Okay, so many types, many causes. How do doctors actually measure how bad it is? Is there a staging system?
Yes, there's a standard clinical staging system used for chronic lymphedema, regardless of the cause. It comes from the International Society of Lymphology.
How does it work?
It starts with a latent phase, or stage 0.
Yeah.
Here, there's some lymphatic impairment, maybe excess fluid or early fibrosis, but you don't actually see any swelling yet.
So it's subclinical.
Exactly.
Yeah.
Then comes grade 1. This is where you see swelling. It usually pits when you press it.
Pitting edema.
Right.
Yeah.
And it often gets better if you elevate the limb. Importantly, there's no significant fibrosis, no hardening yet.
Okay. Then grade 2.
Grade 2, the swelling is usually non-pitting or pits only with strong pressure. Elevation doesn't help much. And there's moderate to severe fibrosis. The tissue feels firmer.
And the final stage?
Grade 3 is the most advanced. We call it lymphostatic elephantiasis. The swelling is irreversible, often massive, and there's significant skin hardening, sclerosis, maybe other skin changes too.
And the staging helps.
It's useful, yeah. Mainly for evaluating how well treatments are working, comparing outcomes. But, judge the degree of fibrosis without actually taking a tissue sample can be a bit subjective sometimes.
Right. Let's shift to how this actually looks and feels for a patient. What are the signs and symptoms that might point towards lymphedema?
Well, the patient's story, their history is often super important. Does anyone else in the family have leg swelling? That points towards familial primary lymphedema.
Okay.
Is it a teenage girl with painless leg swelling that just sort of appeared? Could be lymphedema precox.
Uh-huh.
Are there other symptoms like chronic diarrhea, weight loss? Might suggest a problem with lymphatics in the gut. Seeing milky fluid leak from skin vesicles. That points to chyle reflux.
And for secondary?
For secondary, the history is usually about the cause. Previous lymph node surgery, radiation, history of cancer, trauma, infection, travel to areas where filariasis is common.
Makes sense.
Interestingly, though, whether it's primary or secondary, the actual clinical presentation, the symptoms themselves, can often look very similar.
So what are those common physical signs a doctor looks for?
It really depends on how long it's been going on and how severe it is. Swelling, edema is obviously the main thing.
Right.
Early on, it's often soft, pits easily, maybe goes down overnight or with elevation. In the leg, it characteristically extends down to the foot and toes. You might see square toes.
Square toes?
Yeah, the swelling can make them look sort of squared off. And a key sign is stemmer sign.
What's that?
You try to pinch and lift the skin at the base of the second toe. In lymphedema, because the skin gets thickened and less elastic, you often can't lift it up. That's a positive stemmer sign.
Okay. Any other sign?
Sometimes a sort of buffalo hump appearance on the top of the forefoot. Later on, as that fibrosis sets in, the limb can feel really firm, almost woody.
And what about skin changes? The source mentioned those too, and nails.
Yeah, the skin definitely changes. Early on, it might just look a bit pinkish, feel slightly warm. But with long-standing lymphedema, the skin gets thick, rough hyperkeratosis. It can develop that peau d'orange, orange peel texture.
Due to the chronic inflammation.
Exactly. Sometimes recurrent eczema happens. But actual skin ulcers are less common than with, say, venous stasis disease. The skin in lymphedema tends to stay relatively hydrated and elastic, and blood flow isn't usually the main issue.
Okay.
But if it's chronic, especially with those enlarged, leaky vessels, you can get little wart-like bumps or tiny vesicles that ooze clear lymph fluid. That's lymphedema.
And if it's milky?
If it's milky, that's chyluria from that chyle reflux we mentioned.
Yeah.
And yet, nails can be affected too, especially in primary lymphedema. Sometimes a yellowish discoloration.
Yellow nails.
It's also seen in something called yellow nail syndrome, which often involves fluid in the chest too. It's thought to relate to impaired lymphatic drainage from the nails. You might also see clubbing, ridges, brittle nails, slow growth in severe cases.
Is it painful, lymphedema?
Generally, aching or a feeling of heaviness is common. But intense pain isn't typical of uncomplicated lymphedema.
So if there is severe pain.
That should raise red flags. Think infection or maybe nerve pain, perhaps from scar tissue after surgery or radiation. You definitely want to rule out other causes for the swelling if pain is a big feature.
It sounds like living with lymphedema isn't just about the swelling. What are the main complications people face?
Infection is a really big one, a major risk.
Why is that?
Well, that stagnant protein-rich fluid is just a perfect soup for bacteria to grow in. Plus, the faulty lymphatic system means local immunity is impaired.
Yeah.
It's harder to fight off bugs.
And infections make it worse.
They absolutely do. And infection can cause further damage to the already struggling lymphatics, sometimes irreversible damage. It definitely exacerbates the lymphedema and the skin problems.
Is it common?
The risk is quite high, especially in primary lymphedema. Studies show a high lifetime prevalence of cellulitis. That's a bacterial skin infection in people with chronic leg edema.
And how does the infection show up?
It could be acute sudden redness, heat, pain, maybe fever, or sometimes it's more subtle, just some low-grade redness without much fever. But any recurrent cellulitis is bad news for the underlying lymphatics.
The source also mentioned malnutrition and immunodeficiency. That sounds quite serious.
It can be, yes, particularly if the lymphatic problem affects the intestines, leading to protein-losing enteropathy.
Losing protein into the gut.
Right. Or if you have significant leakage of chyle into the abdomen chylous sites of the chest chylothorax, you can lose large amounts of protein, fats, cholesterol, even calcium.
And the immune system.
Losing lymphatic fluid also means losing lymphocytes, key immune cells plus antibodies, other immune factors, and normal immune cell trafficking is disrupted. So yes, it can lead to immunodeficiency, making people more vulnerable to infections, and maybe even some cancers.
And speaking of cancer, the source noted a risk of malignancy in the affected limb itself.
Yes, sadly, that is a rare but recognized complication of very long-standing chronic lymphedema.
What kind of cancer?
The most known is lymphangiosarcoma. It's an aggressive cancer arising from the lymphatic vessels themselves, usually in limbs with chronic secondary lymphedema.
How does that look?
Often presents as bluish or purplish nodules, maybe plaques or blisters on the skin. It's very serious, often leads to amputation and can be fatal.
Are there others?
There seems to be a slightly increased risk of other cancers too, like Kaposi sarcoma, squamous cell skin cancer, malignant lymphoma, and melanoma developing within the lymphodematous limb. It's rare, but a serious potential long-term consequence.
Okay, so given all these possibilities, signs, symptoms, complications, how do doctors actually confirm the diagnosis? How do they nail it down?
Well, in many cases, especially if it's advanced and long-standing, the history and physical exam findings are pretty characteristic. They strongly suggest lymphedema.
The swelling pattern, Stemmer's sign.
Exactly. But in milder cases or early stages, or if the picture isn't perfectly clear, then objective testing becomes really important. You need data to confirm there's a lymphatic flow problem or the typical fluid distribution.
And what tests provide that data?
There are several imaging options. Lymphoscintigraphy is probably the most reliable and widely used confirmation test.
The one with the tracer?
Right. Near-infrared fluorescent lymphatic imaging is another newer technique. Older methods like direct lymphography are rarely done now, maybe just before specialized surgery. And then there are the more general advanced imaging tools, MRI, CT, ultrasound. They can also provide useful information.
Let's talk about lymphoscintigraphy again. How exactly does that show the problem?
Okay, so they inject that tiny bit of radioactive tracer, usually between the fingers or toes.
Right.
The lymphatic system picks it up. Then a gamma camera tracks where that tracer goes and how fast.
What do they look for?
They look for abnormal patterns. Does the tracer get stuck in the skin? That's called dermal backflow. Is transport delayed or absent altogether? Does it cross over to the other side abnormally?
Yeah.
Do the lymph nodes show up late or not at all?
So it shows function or a lack of it.
Exactly. In primary lymphedema, you might see channels that look obliterated or maybe abnormally wide and leaky, like in lymphangiectasia. You can even get semi-quantitative measures like comparing tracer uptake in the nodes on the affected versus the unaffected side. That can give an idea of severity and sometimes predict treatment response.
And what about CT and MRI? What do they add?
They're really good for showing the anatomy and the distribution of the fluid. Lymphedema typically causes fluid buildup in that superficial layer, the epiphyseal space, while the muscles underneath are usually spared.
Which is different from other types of swelling.
Often, yes. Venous edema might affect both compartments. Lymphedema shows fat, not so much fluid. CT and MRI can show a classic honeycomb pattern of the fluid in the subcutaneous tissue and skin thickening.
Useful for ruling things out?
Definitely.
Yeah.
And MRI is particularly good for seeing the lymph nodes, identifying enlarged lymphatic trunks, or finding causes of secondary blockage like tumors. It really complements the functional info from lymphoscintigraphy.
And those newer techniques, ICGL and MRL.
Indocyanine green, or ICG lymphography, uses a fluorescent dye and is great for mapping superficial vessels, often done right before surgery like lymphatic cavernous anastomosis. MRL, magnetic resonance lymphography, gives even more detailed anatomical maps of both superficial and deep vessels. Really helpful for surgical planning.
Okay. And direct contrast lymphangiography, why is it used so sparingly now?
It gives incredibly detailed pictures, but it's technically hard to do. You have to find and cannulate a tiny lymphatic vessel, and the oil-based contrast agent they use can actually pool in the lymphatics and potentially worsen function. So it's really reserved for very specific preoperative assessments in specialized centers.
Got it. Now, ruling out other things, differential diagnosis seems critical. What are the main mimics of lymphedema?
Absolutely crucial because the treatment can be totally different. Lymphedema is a big one, especially in women. Symmetrical fatty enlargement of the legs, but key difference is the feet are usually spared.
Unlike lymphedema.
Right. And lymphoscintigraphy is typically normal in lymphedema. Then there's venous insufficiency, very common cause of leg swelling. Look for signs like skin discoloration, varicose veins, could be ulcers. History is important.
And systemic causes.
Always rule those out first. Heart failure, liver disease, kidney failure, low protein levels, thyroid problems like myxedema. Even some medications can cause swelling.
So lots to consider.
Definitely. And local things too. Deep vein thrombosis, DVT, Baker's cyst behind the knee, tumors, trauma, infections. The list is long. You have to be systematic.
So once the doctor has gathered all this info history exam, maybe tests, how does the decision-making process work for managing it?
Often, the clinical picture points strongly to the cause. Initial lab tests help exclude those systemic issues.
Right.
If someone's high risk for secondary lymphedema, like a cancer survivor, early detection is key. That bioimpedance spectroscopy technique looks promising for finding stage 0 disease.
Catching it before visible swelling.
Exactly. Venous ultrasound is standard to check for vein problems. CT or MRI might be used to look for obstructions or other causes like tumors or vascular malformations.
And lymphoscintigraphy confirms it.
It's generally the test of choice for confirmation. A normal scan makes lymphedema very unlikely, although chronic venous problems can sometimes cause abnormal lymph flow to lymphedema.
A mix.
Yes. Near-infrared is increasingly used pre-op. But fundamentally, for all chronic lymphedema, the mainstay of treatment is conservative physical therapy.
Compression, massage, exercise.
Exactly. The specifics of who gets conservative versus surgical therapy are complex, but that initial diagnostic workup guides everything.
Okay, let's look to the future then. The source mentioned molecular therapies. That sounds promising. What's happening there?
It really is an exciting area. Current treatments manage symptoms, control volume, but they don't cure the underlying lymphatic defect. The big hope is molecular therapy, especially therapeutic lymphangiogenesis.
Growing new lymphatic vessels.
Essentially, yes, it builds on what we're learning about how lymphatics develop.
Yeah.
There's a family of growth factors, the VEGFs,
Uh-huh.
specifically VEGFC and VEGFD. They bind to a receptor, VEGFR3, mainly found on lymphatic cells, and basically tell them to grow.
And we know this works.
Well, in animal models, yes.
Yeah.
Giving extra VEGFC can stimulate lymphatic growth.
Yeah.
Remember, Milroy disease involves mutations in that VEGFR3 receptor.
Right.
In mouse models mimicking that, giving VEGFC via a gene therapy vector actually induced new functional lymphatics and improved the lymphedema. Similar results in models of post-surgical lymphedema, too.
So potential for fixing the root cause.
That's the hope. There's also work targeting inflammation. A molecule called leukotriene B4 seems involved, and drugs blocking it, like ketoprofen in one pilot study, showed some benefit.
Interesting.
And for complex vascular malformations that often include lymphedema, targeted drugs like mTOR inhibitors are already being used and showing promise.
So are these treatments close?
There's still a way to go. We need much more research to confirm safety, effectiveness in humans, figure out doses, long-term effects, the best delivery method, growth factor injections, gene therapy. But it's definitely the direction things are heading, a shift towards potentially restorative therapies.
This has been, wow, a really comprehensive look into lymphedema. We've covered what it is, that protein-rich fluid backup,
The plumbing problem.
the huge range of causes, both primary and secondary.
From genetics to infections to cancer treatment.
How crucial diagnosis is using clinical skills and imaging.
Lymphoscintigraphy, MRI.
And now, this exciting potential for future molecular treatments. We really aim to distill that expert knowledge for you, our listener, into something clear.
And it really shows, doesn't it, how interconnected everything is. The lymphatics, genetics, inflammation, even cancer development. Understanding lymphedema pushes our knowledge forward in many areas of medicine.
Absolutely. So as we finish up, here's a thought to leave you with. Given all this progress in understanding the basic molecular workings and the inflammatory side of lymphedema, what unexpected treatment avenues, maybe beyond just fixing the fluid or growing new vessels, might actually emerge in the coming years for people living with this condition?